When we hear the word anemia, many people think it only means having fewer red blood cells. But aplastic anemia is much more than that. Deep inside our bones, there is a vital factory called the bone marrow. It continuously produces three important types of blood cells: red blood cells that carry oxygen, white blood cells that protect us from infections, and platelets that help control bleeding. In aplastic anemia, this factory becomes damaged and cannot produce enough of these cells, not just red blood cells, but also white blood cells and platelets. Aplastic anemia, when the bone marrow fails. Inside the bone marrow, a highly organized production system is constantly at work. This is hematopoiesis. At the top of this system are hematopoietic stem cells, also called hemocytoblasts. These cells are multipotent, meaning they can give rise to all blood cell lines. These stem cells differentiate into two major progenitor pathways: the lymphoid lineage and the myeloid lineage. The lymphoid progenitor gives rise to lymphoblasts, which mature into T lymphocytes, responsible for cellular immunity, B lymphocytes, responsible for antibody production, and natural killer cells, which target infected and malignant cells. The myeloid progenitor produces several essential blood components: erythrocytes, or red blood cells, responsible for oxygen transport; megakaryocytes, which produce platelets for clotting; and myeloblasts, which differentiate into neutrophils, eosinophils, basophils, and monocytes, key players in innate immunity and inflammation. Under normal conditions, this system maintains a balanced and continuous production of all blood cell lines. But in aplastic anemia, this entire factory fails. The bone marrow becomes hypocellular, leading to a drastic reduction in all three blood cell lines: red cells, white cells, and platelets. This condition is known as pancytopenia. Although aplastic anemia is a failure of the bone marrow to produce blood cells, the question is, what causes this failure? In most cases, no specific cause can be identified. These cases are called idiopathic aplastic anemia. However, several factors can damage hematopoietic stem cells. Certain medications can directly damage bone marrow or trigger an immune reaction against stem cells. These include chemotherapeutic agents, chloramphenicol, sulfonamides, antithyroid medications such as methimazole and propylthiouracil. Exposure to radiation and chemicals can also injure rapidly dividing stem cells inside the bone marrow. For example, high-dose radiation and toxins such as benzene can impair marrow function and lead to aplastic anemia. Some infectious agents can also be associated with aplastic anemia. Certain viruses, including Epstein-Barr virus and HIV, may contribute to bone marrow suppression through direct effects or immune-mediated destruction of stem cells. Finally, aplastic anemia can occur due to genetic disorders. One important example is Fanconi anemia. Fanconi anemia is an inherited bone marrow failure syndrome caused by mutations in genes involved in DNA repair. Because these cells cannot properly repair DNA damage, hematopoietic stem cells become unstable and gradually lose their ability to produce blood cells. It is the most common inherited cause of aplastic anemia. Patients with Fanconi anemia usually present at a young age and may have features such as pancytopenia, increased risk of malignancy, and congenital abnormalities. These abnormalities may include short stature, microcephaly, developmental delay, café au lait skin lesions, and thumb abnormalities such as absent or underdeveloped thumbs. Despite the different causes, they all lead to the same final outcome: failure of the bone marrow stem cell compartment. Since aplastic anemia affects all blood cell lines, the symptoms are caused by the deficiency of red blood cells, white blood cells, and platelets. When red blood cells decrease, patients develop symptoms of anemia due to reduced oxygen delivery, such as fatigue, weakness, dizziness, and pallor. When platelets decrease, clot formation becomes impaired, leading to bleeding manifestations such as petechiae, bruising, and mucosal bleeding. When white blood cells decrease, especially neutrophils, the immune system becomes weakened, causing recurrent infections. To diagnose aplastic anemia, the initial investigation is a complete blood count. The typical findings include decreased red blood cells causing anemia, leukopenia due to reduced white blood cells, thrombocytopenia due to reduced platelets. Another important finding is a decreased reticulocyte count. Reticulocytes are immature red blood cells released from the bone marrow into the bloodstream. A low reticulocyte count indicates that the bone marrow is unable to produce enough new red blood cells. In response to anemia, the kidneys normally produce a hormone called erythropoietin, or EPO. Erythropoietin is a hormone that stimulates the bone marrow to increase red blood cell production. When oxygen levels in the blood decrease, the kidneys sense this low oxygen state and release more EPO to stimulate the production of new red blood cells. However, in aplastic anemia, this response creates a vicious cycle. Low red blood cells cause decreased oxygen delivery to tissues. This stimulates the kidneys to release more erythropoietin. EPO sends signals to the bone marrow to produce more red blood cells. But because the hematopoietic stem cells are damaged or absent, the bone marrow cannot respond effectively. As a result, red blood cell production remains low, oxygen levels stay reduced, and the kidneys continue releasing more erythropoietin. The definitive diagnosis is confirmed by bone marrow biopsy. In aplastic anemia, the bone marrow is hypocellular, meaning it contains a markedly reduced number of hematopoietic cells. The biopsy shows decreased hematopoietic stem cells, normal cellular morphology of the remaining cells, absence of infiltrative disorders, absence of malignancy, and absence of fibrosis. The marrow space becomes mainly replaced by fat, creating the characteristic empty or fatty marrow appearance. Therefore, the diagnosis of aplastic anemia is based on the combination of pancytopenia in the peripheral blood and a hypocellular bone marrow without evidence of malignancy, infiltration, or fibrosis. Treatment of aplastic anemia aims to restore bone marrow function and manage the effects of pancytopenia. In younger patients, especially those under 50, the main treatment is hematopoietic stem cell transplantation, replacing the damaged marrow with healthy stem cells. For older patients or those without a suitable donor, immunosuppressive therapy is used to stop the immune attack on bone marrow, including cyclosporine, antithymocyte globulin, and glucocorticoids. GCSF may be given to stimulate white blood cell production, while blood transfusions provide support in severe cases. If a drug or toxin caused the disease, removing the trigger is an essential first step.